are you two doing? Can you see my screen, the ATI?
Yes.
All right. So I encourage you to do this on your own also. I'll run through the module, go through IV therapy. I can't show you the pre-test anymore because I'm in as a student. So you're seeing, I'm seeing what you would see. The reason why the pre-test can't be taken again is because this is your baseline. ATI doesn't believe that you should be able to retake the pre-test multiple times because it doesn't make sense. Meaning it's your baseline, so that way you can see how you were before you started the module, and then see what your tests will be, what your grade will be on the post test. Does that make sense?
Isn't the post-test the same questions?
No, I looked at the post test. There are different questions, and then the post test you can take again and again, but the pre test is one time. Okay. Occasionally, I'll be going to your textbook. I finally got a copy of the 10th edition, by the way, instead of the 11th. You guys are using the 10th, right?
Yes.
Yeah, okay, I think so. All right. So over you, I won't do the whole thing. Terminology, if you need it, just look at the what things you don't understand. I don't really know which ones are foreign to you, like bevel. Do you know what the bevel means?
Yes. The very tip of the needle.
Okay,
Slanty
there are
surface.
yeah, there are two types of needles though. One, there are solid needles, and we also have injection needles. This bevel is referring to an injection needle, the one we use for medication administration. So what they did to the steel is cut it slanting. The tip was sliced in half. That way it looks slanted now. And so there will be of course, the hole is now how would I describe this? Let me see if I can show you. Do you see my whiteboard? Probably not. Okay. Do you see it now?
Yes.
Okay.
Yes.
All right. So if this is a piece of steel, what they did is cut it right here, make a slice. So therefore the needle now looks like this, the tip. So this opening here, this is now the bevel. Does that make sense? So this is now
Yeah,
the
yes, it does.
catheter.
Yes.
So this right here is called the bevel. Whenever you start, because this section is now teaching about how you start an IV, IV access. Okay, entry-level nurses like us, we're allowed to start IVs. What we're not allowed to do are PICC lines. You need to train for PICC line. You just need a BSN. So maybe if you're interested in doing PICC lines, you can do that. You work under radiology department, under special procedures. So they employ nurses. I know someone back in Florida. She started her own company actually. At first, she worked for the hospital, putting in PICC lines. But then she got tired of the pay, so she started her own company. Now she covers 4 hospitals in that tri-county area, and you know, she does it per patient now. She's not paid by the hour. You know, the hospital pays her company, you know, a fixed amount for every pick line she starts. Okay, and then now she's employing. Before it was just her. Then the need grew, so she's employing several more nurses now. But she owns the business. So that is the bevel. Um, Okay. Any other terms you don't understand? And let me just scroll down and see if you have any questions. Um, butterfly needles. Do you know what these are?
Yes.
Yeah, these are used to be. We use these for IV access, but now we just use them to draw blood. Because they're not practical because they're made of steel. So they frequently infiltrate, meaning every time the patient moves, touches the needle, no, it's steel, so it can easily poke through the vessel. So they're not practical. They're better used now for just for to draw blood. Cannula. This is a an IV cannula. The HEP locks or the saline locks that we use now for IV access are made of plastic. They're easier, they're pliable, they last longer also. The hub is um, this is where you attach the extension tubing of a IV catheter. So this is the part of the catheter that is sticking out of the patient's skin. So this is where you attach your extension tubing. That way you can access it. You know, you can give medications through it now. Colonization. This is when you have organisms growing in a foreign object. It's only it's most common in IV catheters. No, it's a foreign object, so organisms can grow on it. Central venous catheter. These are central lines. The most frequent access sites are the subclavian, which is on your upper chest, the neck or the jugular vein. Those are the two most common. The drip chamber is the on the IV tubing, the one you squeeze in order to fill with halfway. You fill it halfway with the IV solution so that you can see the there's two purposes of the drip chamber. One is to avoid or prevent air bubbles from entering the line. The other is so that the solution, especially if you're infusing blood, the blood hits liquid and not a plastic surface. Let me explain what that. So let's say this is the piercing pin. And this is the tubing now. Okay, so this is the drip chamber. So this is the part where you spike the bag. So this would be the bag right here. Can you imagine what I'm showing you? Okay, so this is now the drip chamber. So this whole section here is the drip chamber, especially if you're spiking blood. So if this is a blood bag, you don't want the blood dropping onto a hard plastic because this is all plastic, right? The whole tubing is made of plastic. So you want the blood to drop on liquid so that when it drops right here on fluid, on liquid. That way it doesn't get damaged, because if it drops on a solid plastic surface, of course you're hemolyzing the blood. Red blood cells are very fragile. Okay, they easily break. Right, embolus, of course, this is a anything solid, okay, usually a blood clot, or it could be also air, it could be fat, it could be foreign body. Okay, the catheter can become an embolus. That's why you need to have you guys ever discontinued an IV catheter? Like has a nurse ever asked you, hey, can you DC the catheter please, the patient's discharge?
Yeah,
Okay,
yeah, I did one.
okay. um yeah, just be careful you assess the length of the catheter. Okay, if it's a peripheral catheter, it's usually 1 inch long. um Sometimes the tip breaks off, and becomes an embolus, meaning it gets left behind. So if this is a catheter, okay, so I've magnified the catheter and this is the hub, okay. If this is the plastic IV catheter, there's a hole here, approximately 1/4 inch from the tip. This hole is where the blood enters. So there's a needle here, needle actually here. You need that to insert the catheter. So this part here is where the blood enters. Okay, so when you pierce the vein, let's say this is the vein, you enter the vein, blood enters here and then enters the flash chamber. Okay, so it indicates that you have entered the vein. So this hole here can sometimes be, I mean, it's a weak spot on the length of the catheter. So when you pull this thing, sometimes this breaks off and then you only take out this part of the catheter and then leaving this part here inside the patient. So that's a foreign body, and it could circulate around your bloodstream, and it's an embolus. Okay, who knows where it will end up and obstruct blood flow. Okay, I won't finish the whole thing because otherwise we'll run out of time. Next tab, accepted practice. Also, I won't play the whole thing. Okay. These are the common sites where you will start an IV. Did you guys ever have the opportunity, like a nurse asked you to start one?
That's a no for me.
Nope.
No. The best one
No.
was the clinical instructor. I mean, I've had patients who say yes. Of course, I don't tell the patient that this is the student's first time. Not have to lie every now and then, but well, technically, it's not the first time. I mean, student has practiced in skills lab. So technically, I'm not lying. I just didn't say, the the student's first time was on a mannequin, not on a real person. But I mean, if the student can practice, then how do they learn? The ones I frequently practice on are on either comatose patients or those who are intubated. So let's say we have a patient on a vent. So those patients are perfect, okay, because they'll never, say anything because they can't. I don't want to use the word practice, but well, technically, yeah, we're practicing, but it's the best person to practice on, right? Of course, I still practice ethics. We ask we didn't technically ask permission because the patient's unconscious. We notify the patient that what we're doing. We explained it, regardless if they can hear or respond to us or not. We did explain the procedure, and we follow protocol that we can only try twice. After that, then we shouldn't try anymore. So these are the sites. You have the basilic vein, the cephalic. So basilic is always the medial side, and then the lateral side is the cephalic. Back of the hand, very frequent. You can observe your own hands. Okay, also here, much further toward the knuckles. Although we try to avoid those, the best part really are either the cephalic or the basilic. Reason is we want the patients to wash their hands. Now they can't wash their hands if there's an IV sticking out there, right? We try to avoid the antecubital area, which is your the bend of your arm, because that's the worst site it could be. Although you've probably seen in clinical that patients coming up from either from the ambulance or from the ER, they already have one at the antecubital. The EMTs, paramedics, and ER nurses insist that it's acceptable practice. For them, maybe because it's an emergency, it's the easiest spot where you can start an IV, but not for indwelling, okay, not for long-term use, because they don't last long. Patient has to move their arm, they bend it, it infiltrates all the time. This is now the extension tubing. So the hub, so this is the extension tubing. This is what you connect to the hub. And this will of course be connected to the port, the clave port, which is a needleless system. That's what you connect to a luer lock syringe. And this is the tubing. You can have primary and secondary tubings. Okay, this is now your common IV tubings. So a macro, you can see there's no needle here. So if you see one here, then that's a micro drip. This is the size of the tubing. And these are your macro. If none, then it's standard, either 10 or 15. Most frequent, most common drop factor is 10. Again, I'd like to remind you that drop factor indicates the size of the tubing. Okay, so this one, 10, means for every 10 drops, the patient receives 1 ml. Whereas this one, this is so tiny, so it takes 60 drops to deliver the same 1 milliliter. So on your dosage exam, the question may not say the number for your drop factor. So the problem will either say macro or micro. Okay, so micro drip, that's always 60. Any questions so far? For macro, we have to give you the drop factor because some drop factors are, some tubings are 15, some are 10. Any questions so far? You guys still live?
I'm good. I understand.
Yeah, we're still here.
Okay. As far as between primary and secondary tubings, it's not always a rule that the bigger bag is always primary, the smaller bag is always secondary. They can be the same size bags, okay? Of course, we prefer that the longer lasting infusion must be set on the primary line, on the primary tubing, whereas the tubing, the bag that is either smaller or runs intermittently, meaning only runs maybe every 6 hours, every 8 hours, those should be secondary. Okay, that's the general practice. We already know these. We practice these, and I'm still sending you. Some people I owe you second versions. For some reason I'm having problems downloading the attachments on the MAC email, but It's not you. It's probably the website that's not allowing me to download it, but I'll keep trying. IV solutions. It's best you use your textbook for this, but there shouldn't be any major differences. You tested these already, right? In exam 1, I believe. Hypotonic, iso, and hypertonic. So isotonic is always normal saline or LR. These and then anything else that you add dextrose into becomes hypertonic. Exceptions are again D5 water. This one is isotonic. The reason is the dextrose in water only sounds like it's hypertonic. Really, when they enter the bloodstream, they don't remain D5 water. The two components separate. When they hit the bloodstream, dextrose goes one way, water goes the other way. So it's technically isotonic. Same thing for D5 and a quarter. So anything besides these exceptions here are hypotonic whenever you add either dextrose in it, or they are higher than 0.9% sodium chloride concentration. For example, 3% or 5% NaCl. Of course, these are concentrated or hypertonic solutions. Anything below 0.9, like half normal saline, or 0.33, a third percent sodium chloride, these are hypotonic solutions. As you can see, there's not a lot of them. But you can easily change this one to a hypertonic solution by adding dextrose in it. So if you add D5 and a half, then that becomes a hypertonic solution. Same thing for normal saline. If there's dextrose in it now, then it becomes hypertonic solution. Any question about that?
Does it have to be more than 5% dextrose to become hypertonic solution?
Anything over 0.9%. But that's just the standard. It's not very common. I mean, there's probably solutions with less than 5% dextrose, but they're more like special order. They're not routine IV solutions. The pharmacists can mix anything. I mean, pharmacists are chemical majors. You know, they know how to mix drugs, they know how to create them. So they can special order solutions. The doctor could request that. They can create it, but they're not standard. Okay, they're not floor stock. Any other questions? Meaning these solutions here, these are the most frequent ones you'll see on a typical storage. You go into a supply room or the Pyxis room in the hospital, you're bound to see these solutions, okay, because they're floor stock. They're commonly used, so they're frequently stocked on the unit. All right, so how do you secure a catheter? We have stat locks now. We have stat locks for central lines. The stat locks were originally made for central lines only, and then they thought, why stop there? So they created ones for peripheral lines. They created some for Foley catheters now. They even have stat locks for drains. Okay, so if you guys can think of any other tubing that you want to secure, they're open for ideas. Okay, then you can probably stop working and then just be a businessman.
That's the goal.
Yeah. Okay. So where is it now? Okay, assessing and managing. Frequent questions on skills related test questions are on maintenance. Routinely, IV access is good for anywhere between 72 to 96 hours. Okay, most facilities have a 3-day, 72 hours. However, for those who use stat locks, they have a 96-hour policy, meaning as long as the IV site is good, I mean, it's working, it's patent, then it can stay up 3 to 4 days on the patient. If the dressing comes off, let's say the patient sweats or you got the dressing wet, you can change it. Aseptically, you can change it, but we don't routinely change the offsite or the transparent dressing on it. There's really no need to. Okay, it is the MSC website. That's the problem. Did any one of your classmates contact you for, because I can't open the MEC email. Just in case if they're indicating that they need to join, just share the invite. Did anyone contact you?
About what?
About class? But I see no, everybody's here. Never mind. Marcia's here. Hello, Marcia.
Those are some high grades at the side there.
I'm sorry?
No, I'm seeing like grades. Those are some high grades, 94 and 100.
I'm trying to go back to the textbook. So close your eyes. I don't know.
I'm like, wow, which group is that?
Okay, are we back?
Yes.
Okay, all right. So where were we? Okay, so how long can IV access stay? Okay, so they can stay 72 to 96 hours. Again, 96 hours, especially if you have a what is that? Stat lock. Okay, stat lock are stabilizing devices. Okay, IV access stabilizing device. Okay. Do we have complications? Yes, of course we do. These are also found in your textbook. Number one is local infection. And these are the signs. I'll show you in the textbook later where to find these. It's under infusion therapy. Phlebitis is also common. Phlebitis, you can literally see a red streak on the insertion site. It looks red. Definitely may not always look inflamed, but there's a red streak along the course of the vein. The only thing you can do is discontinue it. There's no saving the IV site. Okay, once you have phlebitis, because the vein is inflamed, so you shouldn't use it anymore. So these are the characteristics. It's painful, it's warm, it's red along the vein. So the only action or the only treatment is take it out. And then after that, you apply moist warm compress to reduce the inflammation. Same thing for infection. So if you have signs of infection, you of course discontinue it, but the doctor may want to be notified. So he may, especially if the patient has signs of a systemic infection rather than local, then the doctor would want you to send the catheter to the lab for culture. He wants to know what's growing in it. So if there's something growing in it, it's probably the same thing growing in the patient's blood culture. All right here. So if you have these signs present, especially if there's pus present, then save the tip. Okay, just the tip, not the entire catheter and the tubing. Okay, so just the tip of the catheter is what you put in a sterile specimen container. Just like how you're asked for a stool specimen, when you send a stool specimen, you don't really need a whole piece of turd, right? You just need a small piece in a specimen container. We did that once in the community during our community health rotation, and people were lining up, right, with their specimens, and some people had like whole peanut butter jars full of stool. um so we we had to tell them, yeah, we've had breakfast already, we don't need that much specimen. I guess it was our fault, we were not specific enough. Infiltration is the most frequent complication. The IV sites migrated, it's no longer inside the vein. So all the solution that you are infusing, of course, is not going intravenously, it's around the tissue. Okay. Depending on the solution, if it's non-vesicant, meaning it's not harmful, it's not going to cause tissue necrosis, we call it infiltration. But if the infusing solution is a vesicant, like a really strong antibiotic or a chemotherapeutic agent, for instance, or any other caustic solution, then we call it extravasation, which is now going to be more serious because it will cause necrosis and will require tissue debridement and several months or 1 to 2 years of treatment. Here's extravasation. So this is now the more serious. It's the same as infiltration. The difference between the two is infiltration for regular IV fluids, harmless IV fluids. But if the IV solution that infiltrated is quite strong, very irritating, or a vesicant solution, then that's called extravasation. Circulatory overload happens all the time. It's a common error because we think that the IV fluid was ordered. Yeah, we just keep hanging the bag. As soon as the bag's empty, we hang another one because it's ordered, not doing our job, which is to assess whether or not it's still appropriate. No, this just means the patient received too much IV fluids. Basically it. So yeah, signs, of course, signs of overload, crackles and runs, check the the amount will increase, but what will happen to the specific gravity? NR?
Professor, you was a little muffled just now, so we didn't hear you.
Oh, okay. So what will be signs if you have fluid overload? How will you know?
Professor, you're breaking up. I'm not hearing.
Oh, I was just asking, what are the signs and symptoms if you are, if your patient is experiencing fluid overload or circulatory overload?
Edema.
All right, so they're all here. Again, these are all in your textbook. I'll show you later before we finish. Okay, so we discussed this earlier. I asked Mr. Was it Kevin who answered that you discontinued an IV catheter? Or was it Troy?
It was me.
Right. So your number one responsibility is you have to look at if this, all the catheter, all the pieces of it are accounted for, right? So it's not something minor. If it's missing a piece, you should notify the physician right away. That way, because that's a sign that the catheter broke off, that's an embolus. Okay, that's life threatening now. So that a tiny piece of the catheter may end up in the pulmonary artery or inside the coronary artery or inside the cerebral artery. Questions so far?
What's the how likely is that to happen?
What happens is it's not very common. It happens if, let's say, okay, you see my whiteboard? Yeah?
Yes.
Okay.
Yeah, we see.
Imagine this is the needle, right? So we have an over the needle catheter. I'll just see if I can show you the picture later. So this is the hub, and there will be a button here, and this is the flashback or the retraction chamber. So this is what your catheter looks like. So you have a solid needle. Okay, this is not an injection needle. So the needle is not hollow. Okay, this is a solid steel needle. There's no lumen inside it. We the patient's skin enter the vein and then bury the catheter. So once you hit the vein though, so let's say this is the patient's vessel, right? You hit it. Take note that once blood enters, because you have now, I exaggerated this a little bit. It's not really that far because the distance from the tip to the catheter is probably an eighth of an inch. Okay, it's very close to the tip. So the moment you bury the catheter, blood enters here. So you'll see blood enter in your flashback chamber. So you see blood, you know you're in there. Sometimes though, we end up pushing it too far. So the nurse will have to make an adjustment. So after they remove or pull back on the needle, let's say up to here, inside here, no longer sticking out, sometimes we lose it. So it occasionally we tend to reinsert the needle back into the catheter, and sometimes we miss the lumen. Sometimes the needle goes here and then ends up tearing the catheter, but it's not totally torn. It's just partially torn. So that means the catheter, instead of looking like the catheter now looks like this. Okay, it's now partially torn. So this is the tear here. I mean, it still works. You probably can't see it because you had no idea what's happening inside, because all this is happening while your catheter is inside the patient's skin. Do you understand what I'm saying? So it's now partially broken, and this is really the culprit. So how to prevent this? Once you've already pulled the needle out, do not reinsert it back. I'm probably one of the people who do this until I realized what I was doing, and then I stopped doing that. Did I answer your question?
Yes, you did.
Okay. All right, let's look at the procedure. I really hope we can experience this. That way we get the feel. Some of you will quickly discover that you're a natural at this. You probably heard of stories that nurses, especially the first few weeks that they've been inserting IV catheters in their patients. Every time you go somewhere in the bar, you can't help it. Stare at people's hands or arms, and then when you see the veins, you just drool with the desire to just stick it. Okay.
Perform hand hygiene. Confirm your patient's order for IV access. Gather all necessary supplies. For continuous infusion, this includes the primary tubing, the extension tubing, the IV solution, the time tape, the tubing label, and a medication added label if you plan to add any medications or vitamins to the solution.
By the way, you won't see a separate order to start an IV access. It's understood. I mean, the doctor will just order the IV solutions, what they want the patient to receive, IV medications, and the route. So it's a given now. So they don't have to write a separate order to start an IV access. Does that make sense?
Yes, that makes sense.
Okay, so meaning you have an IV medication ordered, of course you need an IV access. So that's your cue to start it.
Compare the IV solution to the information on the medication administration record, the MAR. Verify that the provider's order and the MAR both indicate the right patient, the right drug, the right dose, the right route, and the right time. Also verify that the correct IV fluid, infusion rate, and duration or volume to infuse are on the record. Remove the IV solution from its packaging and gently apply pressure to the bag as you inspect it for any tears or leaks. Check for color, clarity, and expiration date of the solution. Next, remove the primary IV tubing and extension tubing from its packaging. Then, remove the protective caps from the proximal end of the extension tubing and the distal end of the primary tubing and connect the tubing.
Now this part here may not be necessary because the extension tubing is already connected to the patient's IV catheter. So this step may not be necessary anymore. So this part here, this extension tubing is already connected to the patient's hep lock. Does that make sense? Meaning whoever started the IV site is supposed to attach an extension tubing to it.
Move the roller clamp so that it is about 1 to 2 inches, that's 2 to 5 centimeters, below the drip chamber, and then place the roller clamp in the off position.
All right, so this is very crucial. If you fail to observe this step, meaning your clamp is open when you spike the bag, that's when you have a lot of air bubbles in your line. It's probably okay if it's just a regular IV because you can waste some of that fluid to get rid of, in an effort to get rid of all the air bubbles in the line. But sometimes if it's an antibiotic, for instance, which are very expensive, that's not the best practice, because so you need to, plus you'll waste time because now you'll have to get rid of those air bubbles when you could have prevented them in the first place by closing the roller clamp.
Compare the IV solution with the MAR for the second time. Is it the right solution, the right volume, the right route, and the right time? Next, remove the protective cover from the tubing port on the bag of solution. Then remove the protective cap from the tubing's insertion spike and insert the spike into the tubing port of the bag. Be careful not to contaminate the spike. If the solution is in a glass bottle, clean the black rubber stopper with alcohol before inserting the spike. If the spike becomes contaminated, discard the tubing and use a new infusion set.
So you can't disinfect the spike port once it's already contaminated. Okay, I just want to make that clear. You cannot wipe it with alcohol or any other antiseptic solution. All right, it cannot be sterilized.
Once you have inserted the spike into the bag of fluid, hang the bag on the IV pole and squeeze the drip chamber 2 or 3 times to allow it to fill at least halfway.
Okay, so this step is also crucial next to closing the clamp. So if you fill the drip chamber 1/3 to halfway full, this again prevents any air bubbles from entering the tubing.
Loosen the cap from the end of the tubing. Hold the end over the sink and slowly open the roller clamp to allow fluid to fill or prime the tubing.
So it's not really necessary to be near a sink or a trash can. I mean, if you follow the steps correctly, you're not going to waste one drop of this IV fluids. Okay, it's not necessary to do that. If you follow the steps of closing the clamp, after spiking, you fill the drip chamber halfway or 1/3 full, and then open the clamp slowly. Not a single drop will come out. Okay, if you follow that.
If you use multiple port tubing, turn the ports upside down and tap gently to fill them with fluid and to remove any air.
Okay, so what they're talking about are these white ports here, because they are corners, you know, they're facing a different way. You tend to get air trapped in there if they are present. So to allow fluid to enter those corners, you have to put them upside down as the fluid enters that section.
Once you have primed the tubing, check the entire length of the tubing to make sure there are no air bubbles in it. If you see air bubbles, tap the tubing gently to remove them.
There's really no set amount of air that can cause an air embolus in a patient. We have no evidence, but it's best not to let any enter. Okay, but again, there's really no evidence of how much air exactly can cause an air embolus. So until we do, I mean, it's really best to avoid allowing any air embolite, I mean, any air from entering the patient's IV, I mean, veins.
Replace or tighten the cap on the end of the tubing. Place the time tape on the bag of solution and the tubing label on the tubing near the drip chamber.
I don't know how many hospitals still use time tapes, but these are available. Okay. As far as are we using them, I don't know. I haven't used time tape for since I was in my first 2 years probably of practice.
Gather and dispose of all waste in the appropriate receptacle. Perform hand hygiene.
The purpose of a time tape, by the way, is just for you to eyeball the bag, meaning if you see that it's running too fast, you know, because when you walk by a patient's room or you make rounds, you just stare or glance at the bag. So based on the time tape, if it's running, you just hung it an hour ago and then it's already halfway empty. So that's, you know, that'll be a clue for you. Oh, there's something wrong. You hung it. You know, you somebody entered the wrong infusion rate.
After you introduce yourself, confirm that you have the right client using 2 acceptable identifiers, and verify the provider's orders, including any allergies, leave the room to gather your supplies. When you return to the room, confirm privacy, place the supplies near the client's bedside, and perform hand hygiene. Explain the procedure. Don gloves. If the client is going to receive IV fluids, place the IV tubing within easy reach for connection to the IV catheter.
Okay, so this gentleman already prepared his IV flush and the extension tubing. They're right here. So he's ready to connect it to the IV catheter hub as soon as it is in place. So he'll connect it and then flush the line directly, check for blood return, and then once done, remove the syringe and then attach the IV tubing to the IV access.
Place the tourniquet on the client's arm. Inspect your client's hand and arm. With your index finger, gently palpate several different veins to find the best one to use to initiate IV access. Once you find an appropriate vein, release the tourniquet.
Okay, I don't know if you were observant on how he tied the tourniquet. So he just tied it in a way where it's a one quick release. So as soon as he pulls this end of the tourniquet, it will undo the whole thing. Okay. So there's no knot really to be tied. We also have gadgets now we can use to let's see.
The ones that you use to find the vein?
Yeah, we have vein finders. I don't know if Kings County has them, but I know the city hospitals have invested in these. They cost anywhere from $3,000 to $5,000 depending on the 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 type. But they increase your confidence. Okay, that the plus also um, lessens the number of failed attempts. Okay, because so as long as you can see where you're sticking, then you're most likely to hit it. If your facility doesn't have it, you can use your own. If you have time, you can use an iPhone or any other smartphone that has a flashlight at the corner of the device. Samsung's where the flashlight is in the middle won't work. I mean,
With your non-dominant hand, anchor the vein by gently pulling the skin taut below the insertion site. With the bevel of the needle facing up and the IV catheter at a 10 to 30 degree angle to the vein, quickly pierce the skin. Once you pierce the skin, continue to stabilize the vein, and with the catheter still at the 10 to 30 degree angle.
Okay, I don't know if you were observing, but you saw the blood flash. So now the nurse knows that he has entered the vein. However, he just needs to push it just a tiny bit in order to bury the catheter, because at that point only the needle was in the vein, so the catheter wasn't yet. So he needed to push a little bit more in order to bury the catheter inside.
Gently pierce the vein. To confirm placement in the vein, look for a blood return in the flap.
And then you see how he just pushed the catheter, not the vein anymore. So he just pushed the catheter forward. He advanced it in order to put it inside the vein.
Flashback chamber of the IV catheter. Once you confirm placement in the vein, lower the IV catheter until it is almost flush with the client's skin. Slowly advance it approximately 1/4 of an inch more.
Okay, but at this point, since you're still advancing the catheter, do not remove the needle yet, or do not press the safety retracting device yet, because you still need the needle in order to keep the catheter stiff. Without the needle, this catheter is like a wet noodle. It will not advance on its own. It needs to have a backbone, so to say. Okay, so you need to keep the needle in. So all you did was just pull back on the needle so that the needle isn't sticking out of the beyond the catheter anymore, because you don't need it to be like that anymore. Again, you only need the needle to pierce the skin, enter the vein. Once you've entered the vein, you just pull back on it and then allow the catheter to go in.
Loosen the needle from the catheter and slightly pull back on it. Make sure it doesn't extend past the tip of the catheter. Next, advance the catheter into the vein with your thumb or thumb and index finger of your non-dominant hand until the hub is resting against the insertion site. Apply pressure approximately 1 1/4 inches, that's 3 centimeters, above the insertion site with your middle finger, while stabilizing the catheter with your index finger.
Okay, the purpose why we put pressure here is to decrease the flow of blood, because without the needle, blood will be flowing out because you occluded blood flow by putting on the tourniquet. So of course there will be a lot of blood pooling here, unable to return fully to the heart. So the blood is pooling here, so of course it will flow out here once you remove the needle. So before you remove the needle, pull the tourniquet off first and then apply pressure on this area to decrease the flow of blood, okay? Because you'll need to attach the extension tubing, because otherwise you'll have a bloodbath here. There will be a lot of blood coming out if the tourniquet stays on. All right, so you're already done with inserting the catheter. This time you just need to secure it, connect the extension tubing, so you don't need the tourniquet anymore.
Stabilizing the IV catheter with one hand, release the tourniquet with the other. Remove the needle and activate the safety device. While still applying pressure above the IV site, quickly connect the saline lock to the hub of the IV catheter. Check for patency by injecting a small amount of fluid.
Okay, so you have blood return, and then so
Once you confirm
that.
patency, secure the IV catheter using a securement device.
So this is a stat lock. This thing is sterile. This would be the best thing to do that. If you don't have that, then a simple transparent dressing will also do. But again, this thing buys you an additional 24 hours if you put it on. I mean, if you use it.
You may use a skin protectant under the securement device to help prevent skin breakdown.
So what he's using is called the skin prep. This will protect the skin from the adhesive, because imagine this adhesive will be staying on the patient's skin for a whole 72 to 96 hours, irritating it. So if you put a skin barrier or skin protectant, the adhesive sticks on the protectant, not on the patient's skin. So that's why they call it a skin barrier, because it leaves a thin film of it's like a second skin, right? On the patient's periskin. That way, again, the adhesive sticks on that skin protectant, not directly on the patient's skin. It's okay to fumble your way here. This obviously has done it several times before, so that's the only reason it's very comfortable.
Remove the backing from the transparent dressing, place it over the insertion site and up to where the hub and the tubing connect. Be careful not to place it over the hub and tubing connection.
I will have to disagree with where he taped, because what the hell is he taping? He's taping the skin. We're supposed to keep the sterile parts covered, because here you need to tape the insertion site as well as the stat lock. Okay, because I'll show you what I mean. Okay, so the insertion site is right here. Okay, so see how the tegaderm is covering only this part instead of this part also, because all you really need exposed is this one, so that you can, in case something happens, you can disconnect this. But this is way too, because we really don't need to cover this area here. Okay, and sometimes also it even helps because we rarely need to disconnect the patient from this. It's also okay to cover the entire thing, including the connection, this part of where the hub connected to the extension tubing. You can also cover up to that area there.
You can save a piece of the transparent dressing to note the date and time of the procedure to place on the IV dressing site later. Finally, loop the tubing next to the IV site and tape the tubing to the client's arm.
Okay, and voila. Any question about that part?
Professor, how long would you say it took you to master that part?
Oh, you can put in the IV from start to finish, probably under 3 minutes or even quicker. 3 minutes will be would be the longest. The longest part is before. It's really the selection of the IV access. You have to look for the best one. This would be the best part, the arm rather than the back of the hand. Nothing will disturb that part. Of course, we work with what the patient's got. Okay. Again, if you don't have a vein finder, you can use your phone. If you guys have a dark room there and you have an iPhone, you can turn on your iPhone's flashlight and then as long as you're in the dark room, you could put it against your skin, not over your skin, but against your skin. It will show you dark lines underneath the red light from your flashlight. Okay, so I use that all the time because I don't have a vein finder. There are cheaper ones costing about maybe $140. They're good enough to show you the vein. It'll work, especially if you want to practice, and then get the feel of it. Then that would be a good way for you to start. Any question, guys? So please do the post test on your own. Just want to show you where the vein finder is. Oh, okay, here it is. Okay, parts of a needle. So this is the most commonly used type. This is made by, this is Insight by, I think Bard makes these. Almost all hospitals use it. I know the city hospitals use these. This is uh, this is a button that you press that will retract the needle when you're ready to do so. So this is again after you already seen flashback and you have advanced the catheter. So you only need the needle sticking out beyond the catheter in order to stick the patient's skin. Once you're in there and you saw flashback into the chamber, then after you inserted this, so put pressure over here and then press that button, it will retract it. So no needle sticks. This is a vein finder. This particular brand is $5,000 or more. But as you can see, it's very effective. It will show you that much, okay? Meaning it will illuminate the veins on the patient's skin, patient's arm, making it almost impossible to miss. Any questions, guys? Hello?
No, we're here.
All right.
No, Professor.
Yes.
No questions. I'm good.
Okay. 650. All right, this is your textbook. Blood transfusions. All right, so we saw how to initiate IV therapy, hang a start IV infusion. So now comes blood component therapy. These are the indications for your blood products, table 30-31, page 648. So packed red blood cells, these are what they're used for. Frozen red blood cells. This is obviously for auto transfusion. Some Jehovah's Witnesses do this, but apparently not all Jehovah's Witnesses do. You know how, who are Catholics here? I just want to show an example. Okay, I'm Catholic, but apparently there are different what is this, levels of being Catholic. So same thing as let's say the Jewish religion, for instance. Okay, there are different types of Jewish groups, right? So the same thing for Jehovah's Witness. So some Jehovah's Witness absolutely do not receive blood transfusion, not even their own. But some Jehovah's Witness are open to the practice of receiving their own blood. Okay, but again, that's not the general rule, though. Those are some of the exceptions. So it's possible to do auto transfusion, meaning this is your own blood. We do this all the time. If we have elective surgeries, let's say you're planning to have 1 or 2 knees replaced, so you can deposit your own blood, freeze it, and then by the time you come for your surgery, because there has to be at least 2 to 3 months before, between a blood. For those who donate blood, that's why if you donate whole blood, you're not eligible for donating blood for at least 3 months or more. So the same rule applies. So technically, you're donating blood to yourself. So this one, though, is frozen for future use. So when it comes for your time for your surgery, they thaw that blood and then you receive it. Platelets, because of the lifespan of the platelet, they're not routinely transfused. They're not easy to donate either. The donor does apheresis, and typical donation lasts anywhere between 2 to 3 hours, so it's not easy to get it. Plus, they only last for a few days. So this will be given only if absolutely necessary. Usually the threshold is around, if your if your platelets are under 20,000, then that will be the indication. Unless you are actively bleeding, then that's an exception. Fresh frozen plasma, this is in deficiency of clotting factors. We just finished DVT management last week. So let's say your patient with DVT or PE is on warfarin and they ended up taking too much of the warfarin. So to manage that, since vitamin K won't cut it anymore because the INR is way too high, then fresh frozen plasma would be your antidote. Albumin is routinely given in dialysis patients, also in liver failure patients. Cryoprecipitate, these are for select patients with clotting problems, which did you guys finish already chapter 30, is it 38 or 40? Or you have the...
We didn't reach to that yet. We're wrapping up cardiac tonight.
Yes. All right. Okay. So blood transfusions, here are some action alerts. So you can only use normal saline. You can't use any other solution to prime your blood tubing, okay? And don't mix anything else, right? No additives, nothing. So that's for safety. As soon as you get the order, first thing you do, of course, is check for consent. Or if there's no consent signed yet, ask for consent from your patient. Because once they say no, then there's no need to proceed further, right? So the first thing you do again after you get a order to transfuse is to talk to the patient, ask for consent, and then you can proceed with drawing blood for typing and cross-matching and all that. This is very testable. It may sound elementary, but we still ask these because the most common, I shouldn't say most common, but the most common cause of a hemolytic reaction, which is the most serious, is ABO incompatibility. It's less likely to occur now unless people take shortcuts, or if it's an emergency situation wherein we take shortcuts. I mean, we're pretty good with typing and cross-matching nowadays. Okay, you need to read this. This especially with delegation questions. Okay, on your exam, the instructor may ask you who can do what, and that involves delegation. So let's say in this current crisis we're having, you are down to a few nurses, so you have to use your assisted personnel. Your assisted personnel consists of LPNs, unlicensed assistive staff, and other people. So who can you send to do what? Okay, so very important to know who can do what. As far as the transfusion itself, the person hanging it, the person assessing the patient should be the RN in charge of the patient. Okay, so please read. I won't read them for you. Take a look at the LPN. So we need 2 people to check blood, right? So since LPN listed here, the role of the LPN is to assist the nurse with patient identification and blood product identification. So the LPN can be your second nurse. So you don't really need 2 RNs to do the transfusion. You just need 1 RN actually hanging the blood, but the person checking, double checking with them is the LPN. But see also here, the LPN can monitor the blood transfusion rate. All right, so I just want to make clear what can be delegated to who here. As far as the UAP, be careful about which vital signs they're allowed to take. Okay, so which vital signs is listed here? What vital signs can the CNA take?
They could, well, the LPN could take blood pressure. You said CNA?
But here, it's really depending on which vital signs during the procedure can you delegate to a CNA. It's the vital signs before you start the transfusion and the vital signs after the first 15 minutes. Is this clear?
Yes.
Okay, so here's the procedure. So you take the vital signs before the transfusion, and then you stay with the patient during the first 15 minutes. All right. So because here's the rationale. The most reactions occur during that time. So therefore, the first 15 minutes, who takes those vital signs once the transfusion has started?
The CNA. Oh, the nurse.
This one has to be the RN. Again, let me repeat. So before the transfusion, you take baseline, right? So that can be done by the UAP. Again, you're a very busy RN. So you can delegate that. So you ask your CNA, because nothing's happening yet. So you ask your CNA, can you please take a set of vital signs for me? No problem. So your CNA gets it. And then now you've started the blood, you've checked it with the LPN, right here. Okay, so everything's good. All right, so you both sign, and then the RN hangs the blood, connects it to the patient, and then stays with the patient while the blood is entering the patient's bloodstream now. So the RN stays with that patient for the first 15 minutes or the first 50 ml of blood. Now, 15 minutes later, who takes the vital signs?
The CNA can take it at that time.
Not this one. Okay, then the RN should take it 15 minutes later. The blood pressure here, this one is saying after the first 15 minutes. So let's put times here. So let's say I'm the RN, I started the blood transfusion at 5:30 p.m. We need a set of vials before 5:30, right? Before I started. So at any time before, I can have the CNA take that. So that clearly says here, before the transfusion. I have to stay with the patient first 15 minutes. So therefore, at 5:45, who takes that blood pressure, that set of vital signs?
The nurse.
I have to take it myself. So I take it, fine. The patient's blood pressure, temperature, heart rate, all remain within normal. So at 6 o'clock, who can take that set of vital signs?
The CNA.
It is now the CNA. Is that clearer?
Yes.
Alrighty. Here's another warning. If let's say something happens, okay, you're supposed to start the blood, but then the patient left. You had no idea the patient had to go to a CAT scan. Okay, the damn transport people didn't tell you. Okay, so when you got back to the unit, you have the blood with you, but then the patient is gone. But then they only told you, oh, he'll be back in an hour. So what do you do with the blood? You see my textbook, right?
Return it to the blood bank.
Okay, very good. So it has to be given right away. So the moment you take it from the blood bank and you reach the floor, you can't stop by to smoke a joint or smoke cigarette, chat with somebody. So you have to go from the blood bank straight to the,
Darn it.
right? You can't refrigerate it on your nursing unit because that's not the proper temperature for storing blood. Plus, it's just nasty. You put blood there along with your dinner and other foods. Okay. The first 15 minutes, by the way, should be 2 ml per minute. So that's very slow. So how many mLs per hour is that?
120.
Okay. Probably a little bit less also would be better. Okay, here's a few more details. If rapid replacement is necessary, you have to use a blood warmer. Blood warmer is a machine. It looks like a sandwich maker, and it has its own what is this? A something like a tubing you put through it, so the blood goes into that sandwich maker, which warms the blood before it enters the patient. So you have up to 4 hours to do a pack red blood cells. Not so for platelets. Platelets, you only have, what does it say here? Here, 15 to 30 minutes. Okay, it's not all the same. Because again, platelets are very fragile. They don't last long. They have to be infused quickly. Same thing for plasma, fresh plasma. Do that for you. And I don't know which Dr. Grant will test you on. So they're all listed here. So all of it will be, you'll have to read because you need to recognize, number one, Okay, you have to recognize what is happening, and then you have to know what to do, and then prevention. Okay, so that will cover everything. So this is again table 30-33. There's really no such thing as which one is most common. Yeah, they're all testable. Massive blood transfusion reaction is if your patient receives multiple blood transfusion in a single day. This will, because we use citrate in order to preserve the blood. Have you ever wondered why the blood doesn't clot while it's inside that bag? They use citrate. So there's that citrate inside that bag to keep the blood fresh and prevent it from clotting. You can say citrate is like a preservative. Okay, here it's a storage solution. However, we don't know how long the blood has been in storage. Meaning, I mean, they put a date there, but since donated blood can be stored for months. However, take note that how long can red blood cells live? About 120 days, right? So that's about up to 4 months. So are all the red blood cells the same age when they were donated? I mean, were they all newborns by the time the donor donated it?
No.
No, they have different ages, right? So some red blood cells may be newborn, some of them may be a few days old, some of them were probably ready to die. Okay, so we don't know. All that blood cells in that bag donated by the donor have different ages. So during storage, do more of them die?
Yes.
Yes. So what do dead cells spill out? Let's say a cell dies. What do their guts spill out?
Lactic acid.
And potassium, right? So that's why this will explain the patient's manifestations. So that's why there's hypocalcemia, is because of citrate. Citrate binds with calcium, so now you don't have free calcium anymore. The calcium in your blood becomes calcium citrate, which is not free calcium. Meaning, if calcium is now a compound known as calcium citrate, it goes to the bone now. It can't be used. I mean, this is now not the free calcium that enters and leaves the cell. They can't do that anymore because now they are compounds. They are now calcium citrate. So therefore, you will lose serum free calcium. So that leads to hypocalcemia. And I already said that here potassium will leak from dead red blood cells during storage. So these are the two manifestations if a patient receives multiple blood transfusion reactions. Blood transfusions. So let's say the patient receives 2 or more units of blood, monitor them for hypocalcemia and hyperkalemia. All right, and then the rest, please read on your own. Some of them are quite simple. Again, the most serious is this one. This will kill the patient because they can go into acute kidney injury. That's the most serious. Although we do have febrile. Febrile is not always cause for concern. Okay, unless the temperature spikes really high, then that's not febrile anymore. That's now called sepsis. Okay, so if the fever is really high, then that's not febrile reaction anymore. That's sepsis. For febrile reaction, it's not really serious. It's only a one degree rise. Okay, from baseline temperature. So it's not really life-threatening. And although you stop the transfusion, you can restart it. Okay, so if the doctor tells you, oh, just give him Tylenol, and then you can continue with the transfusion. Okay, so follow the actions here, but since they all say do not restart, that means what did you do in any of these transfusion reactions? What the first thing you do? When you see any of these signs?
Easy.
Sorry, Maria?
Discontinue.
I didn't hear you.
Discontinue the transfusion.
Yes, stop the transfusion and then follow the next steps. Okay, so that means anytime here it says do not restart, meaning it can be restarted, right? I mean, are these serious reactions? Obviously not, because it says here do not restart, so that means you can continue, but you just need an order to restart. Except this one, of course, you have anaphylactic reaction. So this one, it says do not start, do not restart, period, because you can't. I mean, the blood caused the anaphylaxis, so of course we can't restart. Okay.
Yes, I have a question.
Yes, boss.
So when you say restart, you do the thing all over again, and it's
No, you continue. It says you can restart you can continue the transfusion.
or restart is continue.
Yeah, meaning let's say here on febrile, right? It says give Tylenol and then continue the transfusion. The same blood. You didn't change the blood, okay? It's the same bag. You simply gave a Tylenol, or this one you gave Benadryl here. Gave
Professor, would
and
that mean like you stop the blood transfusion and then give the Tylenol and then after you restart it back?
yeah, of course, all of these need the doctor's order, meaning after you stop the transfusion and then continue the saline, you call the doctor, tell them what's wrong with the patient, and then he'll give you, let's say in febrile reaction, doctor will tell you, okay, give him Tylenol and then continue with the transfusion. Okay, that's what it means. Does that make sense? Okay, and then prevention, the same thing. Please read here. So obviously, to whom did this reaction happen to? Here, patient. Yeah, so these are patients who either have cancer, for instance. Okay, so these are the prevention. Consider leukopoor, because meaning blood that has less white blood cells, because they can do that. They can wash. The term is washing. They'll wash the packed red blood cells. Here, that's the term that they mean here. When they wash it, meaning they remove as much white blood cells in there, because that's what's really causing the reaction. It's the donated white blood cells causing the fever. Okay, so this is that's why they put this as a prevention. Okay. Any other question? Again, you need to read all three columns down. You need to know how do you recognize it, because that's what you're paid to do. Okay, you just don't start blood transfusion and then leave, right? So you're monitoring the patient. So if you see these, then that's a acute hemolytic reaction. Then you stop the transfusion, and then depending on how soon you stopped it, look at what happens. The patient goes into DIC, and that's, look at this: acute kidney injury, shock, cardiac arrest, DIC, death. Okay, so this is the most serious of all. So not all are serious. Let's say circulatory overload. This could kill the patient if you did not monitor. This usually happens in elderly patients who cannot tolerate large infusions of fluids. So yeah, and these are the signs, obviously signs of fluid overload. So same thing, you stop the transfusion, call the doctor, and he may tell you to, okay, so restart it slower. Unless the patient can't tolerate it, then stop the transfusion. But of course, you can you can prevent it. In the first place, the doctor should already anticipate circulatory overload anyway, especially if the patient has heart failure. sepsis, of course, that's also dangerous. Or this one, acute lung injury, because this can lead to ARDS, respiratory failure. The table 30-4 are not very common, so I doubt if Dr. Grant will test this other table. But this one, the first one, table 30-33, these are the most common transfusion reactions. Questions, guys?
No questions for me.
Alrighty. See you next week. I'll send the recording in case you need to listen to it.